Good morning, good afternoon, good evening again, everybody. Welcome. My name is Sanyukta Mathur. I'm a senior associate at the Population Council and the senior technical advisor for gender and youth for Breakthrough Research. Breakthrough Research has developed a set of research and learning agendas that identify priority questions for social and behavior change evidence generation. A persistent challenge that we found in the RLA process was the need to better understand whom to reach, how to reach them, and with what kind of SBC programming. Today, we are focusing on segmentation methodologies, a set of evidence generation approaches that facilitate more in-depth and nuanced understanding of the individual and contextual drivers of behavior. We will hear about how segmentation approaches are being applied to current SBC work across various health areas and with different audiences. And hopefully in an engaging discussion with you all, consider how these approaches can help us design and evaluate appropriate SBC interventions. A few housekeeping issues as we get started. Kindly note that this webinar is also being offered in French. To select your preferred language, click on the interpretation bar or icon at the bottom right of your screen and select your preferred language. And then to hear the interpreted language, only click on the mute original audio option. And please reach out if you have any questions with those instructions. Oops. We feel free to ask questions in the chat in either English or in French. We will be closely monitoring the chat throughout the webinar. A reminder that this webinar is being recorded and a link will be shared along with the resources highlighted during the webinar in the next few days. And with that, let me give you a little overview of how we are going to spend the next hour together, hopefully. We're going to hear three very brief presentations from colleagues who are joining us. The first is a video on improving community health worker performance in Uttar Pradesh, India. This will be a video from Hannah Kemp. Hannah is the Vice President of Impact and Growth at Surgo Ventures. Surgo is an organization focused on bringing together behavioral science, data science, and AI to achieve health outcomes. Hannah leads a broad portfolio of behavior change programs across Surgo, from improving maternal health outcomes in the US to empowering women with modern contraception in India. Next, we will hear from Leanne Doherty on creating reproductive and maternal health behavior profiles for women of reproductive age in Niger using cross-sectional survey data, latent class analysis. Leanne is a public health expert with over 20 years of experience in research, management, and technical assistance. Her research focuses on informing demand creation strategies for public health products and services and many of social and behavior change approaches in sub-Saharan Africa. Leanne is a senior implementation science advisor for Breakthrough Research, a global initiative focused on generating evidence and promoting its use to strengthen SBC programming for improved health and development outcomes. And our third presenter is Jessica Vandermark. And she will be speaking on segmentation, SBC examples, and lessons learned. Jessica is a partner with Camber Collective, a strategy consulting firm with a focus on the social sector. She has been working in the field of global health and applying segmentation to SBC strategies and programs for the last 8 years. And with that, we're going to launch right in. I'm going to pass to my colleague to start the video. Thank you.
Serve their community more effectively. There's a lot of different programs and policies that have aimed to shift what an ASHA is doing. So for example, trainings or different incentive structures or increased supervision and monitoring. But these interventions actually haven't led to behavior change at the level that's needed to get to the desired impact on outcomes. By outcomes, I'm meaning mortality. To create lasting change, we really need to understand why ASHAs are doing or not doing certain things and what's the context in which they're making these decisions. We turn to cubes to really holistically explore all of the different factors, barriers, enablers that are affecting what ASHAs are doing and the context that's shaping her behavior. cubes really informed all aspects of the design. So first we use cubes to guide the literature review and really identify what's known and where the gaps exist. So after mapping all the existing literature on ASHA performance onto cubes, we actually recognized we needed to go deeper. And so we took a mixed methods approach, first conducting qualitative research and then quantitative research. In the qualitative research, we attempted to really understand all the potential factors that are driving ASHA performance, how she's interacting with the community, what is the system, how is the system actually impacting what she does and why she does them, what's her personal motivations and beliefs. And we did that both using journey mapping and structured immersion interviews. A number of the things that came out in the qualitative research, we felt like we really needed to quantify. So for example, several ASHAs had told us that delays in receiving their incentive payments were actually really demotivating and causing her not to perform all of the things that she should and could be doing. And so we said, okay, we really need to quantify this. So we turned to, we developed a large instrument where we surveyed 1,500 ASHAs across the state of Uttar Pradesh in a statewide sample. Cubes there was central to the study design in that it didn't tell us necessarily what are the questions to ask, but it really serves as a checklist to help ensure we had all the questions that covered all of the different drivers of behavior. I mean, we learned a lot about what's driving ASHA behavior, but the big thing that I think really stood out is not all ASHAs are the same. So when we looked at the quantitative study of 1,500 ASHAs, we actually turned to a technique that's commonly used in the private sector called psychobehavioral segmentation. So using artificial intelligence, we were actually able to segment all of the 1,500 ASHAs into 5 different groups. These groups all differ both in their performance, what are they doing, but more importantly, why, what's driving their behavior. And this showed us that we need a more tailored approach to training and development of ASHAs in the workforce. So for example, there's a group of ASHAs that are financially troubled. They don't need more clinical training. They actually really need support in getting the incentives that are due to them. And if they felt reassured in that front, it would actually enable them to do more in their community. There was another segment of ASHAs, though, that were highly motivated, but lacking particular types of clinical training. And so these women don't necessarily need to be monitored or pushed to work more hours, but they actually needed to be given enhanced clinical training. One cool thing with the data is that you can actually ask 3 to 5 questions on a piece of paper and I'd be able to identify which segment an ASHA belongs to. So you can imagine an ASHA supervisor being able to have a conversation with a member of her workforce and then be able to, maybe refer them to the right type of training or maybe be able to provide tailored, targeted hands-on support around the incentive process. Zooming out from this, there's a lot that we can take away from this approach and the need to really understand how communities are different, how people are different, and move beyond one-size-fits-all approaches to target particular interventions to particular communities that need them the most.
Great. And can I invite Leanne to give the next presentation?
Good morning. Thank you, Sanyukta. And also just wanted to say hello to everyone. I'm watching the greetings come through on the chat, and it's really great to see such a broad representation from all over the world. So welcome, bienvenue, and I look forward to sharing this presentation with you. So we are sharing findings from a baseline study we conducted in Niger for the RISE 2 program, where we created reproductive and maternal health behavioral profiles for women of reproductive age using latent class analysis. Next slide. So to improve health outcomes, we need to understand the behavioral determinants and barriers for health seeking. We know effective SBC interventions use audience segmentation to develop tailored SBC approaches that are likely to resonate with an audience subgroup. When I refer to audience segmentation, I mean the practice of dividing an audience into subgroups based on demographic, psychographic, geographic, and/or behavioral factors. Audience segmentation, especially demographic segmentation, has been used quite a bit in family planning programs. And audience segmentation using psychographic factors has been used to understand high-risk populations for HIV/AIDS programs. There has not been much of any application of audience segmentation for maternal health programs, nor for integrated health programs. Next slide. Next slide. Oh, thanks. The objective of the study I'm sharing today was to develop maternal and reproductive health audience profiles using both socio-demographic and behavioral determinants to inform SBC approaches for audience subgroups. As I mentioned, the data were from a baseline cross-sectional household survey in Maradi and Zender regions of Niger in both intervention and comparison sites for the program. Data were collected in April and May 2021. We interviewed 2,709 married women of reproductive age. And to create the audience subgroups, we used an analytic approach called latent class analysis, where we identified socio-demographic and behavioral determinants, and then applied the analytic technique to empirically generate audience subgroups based on patterns of responses across study participants in the survey data. Once we generated the audience subgroups, we were then able to test associations between the subgroups and key outcomes, which included 4 or more antenatal care visits, facility delivery, and contraceptive use. Next slide. For behavioral determinants, we constructed questions that drew from behavioral theory. We included questions for each health outcome: antenatal care, facility delivery, and contraceptive use. The specific questions aim to assess study participant knowledge, attitude, norms, self-efficacy, and partner communication about the behavior. Next slide. So as I mentioned, we constructed models to identify audience subgroups based on patterns of responses across the study participants and using survey data using latent class analysis. So to illustrate some of our findings, I'm sharing an example of one of the behavioral profiles where the analysis generated 3 audience profiles. There are 2 bar charts, and we see the 3 audience profiles which were generated through latent class analysis. And we've labeled these weak determinants, mixed determinants, and strong determinants. The first chart illustrates socio-demographic characteristics. It's a lot of data, so I'm going to highlight some key indicators. First, for age, we see that for the sample overall, the navy blue bar is about 17% of women are between the ages of 15 and 24. But in the weak determinant profile, they are slightly younger, about 21%. For education, we see for the overall sample, about 15% have any education. But for the weak and mixed determinant profiles, this is less than 10%, meaning that they're slightly less educated than the sample overall. And for the wealth index, we see that the weak and mixed determinant profiles are much poorer, with over 50% of the weak and mixed determinant subgroups falling into the poor category, when for the sample overall is about 1/3. Next, we review the behavioral determinants, and we find that while the profile with strong determinants has over 90% positive attitudes, social norms, and partner communication, the green bar for the weak determinants is considerably less. And the orange bar for the mixed determinants shows a mix of positive attitudes and partner communication, yet weak social norms. Next slide. So this is an example of how we generated a more nuanced reflection of audience profiles for maternal and reproductive health programs. This information can be used to inform strategies to increase use of maternal and reproductive health services. As we saw with the facility-based delivery, the mixed determinants group shows that the audience may be primed for behavior change if programs take a focus on social norms. And while not shown here, we also found misalignment in attitudes and social norms related to family planning, suggesting a need to promote strategies that address these differences as well. Thank you.
Thank you, Leanne. And if I can ask Jessica to give her brief presentation, I hope all the many colleagues who are joining us from around the world are taking a minute to reflect on these brief presentations. And we'll have lots of time for discussion, so please do post your questions in the chat. Jessica?
Yeah, thank you so much. And thank you to everyone who's participating in the webinar today. I'm honored to be able to present as part of the Breakthrough Action Project. Next slide, please. So I think we saw a couple great examples in these first two presentations of different approaches to conducting segmentation. It's a question that's often asked, is there one right way to do it? Can I use existing data? Do I need to do a nationally representative survey, etc.? This slide attempts to lay out a framework for how you might think about which methods or combinations of methods might be useful. And that really depends, at least in this example, we're showing, for example, on the far left side, if it is a segmentation that is hoped to be used to develop national level strategies or do forecasting, those sorts of things, you perhaps want to have some quantitative data, and leading up to quantitative, doing some expert consultations and qualitative interviews, etc. But then moving to the far right side, this is a simple example, diversifying fundraising contact base. Those are questions, health behavior questions that are deeply seated in social norms and can be quite sensitive. Might be difficult to do with a lighter method, but something like this, where there's really not entrenched beliefs behind it, might be something that could be accomplished through some focus groups, some secondary data, etc. And so we have examples of different segmentations that have been done using both qualitative and quantitative data, and certainly it's possible to do based on existing quantitative data that's available and even DHS data. Next slide, please. This is an example of a more robust process that has been conducted. Here it's been called national demand analysis. You'll see that segmentation is just one component, but a very important one. But really this process would start with landscape analysis, supply and demand analysis, if it's in the context of family planning, segmentation, which can then be used for recommendations, forecasting, and action planning. So this is to show what a more robust process might look like and where segmentation might fit into it. Next slide, please. I think it's important to note that USAID and other donors have been applying segmentation in SBC for family planning, but also in other health areas. You can see here in the map that there's been a lot of work done, particularly in reproductive health. And I should note as well that the projects listed and the segmentations listed here are certainly not exhaustive. These are simply projects that Camber has been involved in some shape or form. So a lot of segmentations based on family planning, but then now in 2021 and some that are ongoing, also looking at malaria and nutrition. Both segmentations done amongst populations of women, of men, and also in some cases providers. And for a lot of these, there are available data sets for those that are interested. Next slide, please. So I wanted to end my presentation with a few reflections, challenges and opportunities for segmentation. What are some of the key topics or questions that come up? One thing I think is important if we look at the challenges on the left-hand side, in the private sector, segmentation really is used quite often for prioritization. A private company might decide that a certain group of people, for example, those that are very loyal to their competitor brand, is maybe just not worth the effort. And so they might prioritize segments based on a number of criteria and choose to really only focus their budget and resources for some segments. In the context of public health, this can be a bit tricky. I think we all want to reach as many people as possible with our public health efforts. So the concept of prioritization doesn't always translate well in the context of public health. So it's interesting to think about whether or not or when we should apply a concept of prioritization using segmentation. The next point, this need for a profiling tool. I think Hannah's video gave a really great example of a profiling tool of simply 5 questions that were needed to identify the segment of ASHA. This becomes more important when the segmentation is not based on demographics. You can't look at the person and know which segment they belong to. You have to ask a few questions about their attitudes, beliefs, and behaviors. Oftentimes those can be quite simple, like the tool Hannah showed, but it does require an additional step that needs to be thought about for implementing and integrating into programming. The third point is something that we're all working on and hoping to have more and more use cases to show. So how are these segmentations being applied? How do we measure the impact of using segmentation? Is it versus a program that does not use segmentation? Is it versus no project or no program whatsoever? So I think we need more data and more use cases to share on how these powerful tools are actually being used in practice in SBC. And we have several, but of course we'd like to have more. In terms of opportunities, I think we saw that these can be used for strategy development, innovative tools, impact forecasting, etc. So it really does have a lot of application uses. There seems to be an increasing interest in the methodology, as evidenced by this webinar today, the attendees, etc. So more and more people are really considering this use in SBC. There is a wealth of resources and training available on segmentation, which we can share those links in the chat, and also after this presentation. There is free online courses to walk through really step-by-step some of the detail we weren't able to get to on today's call, and lots of examples of where it's been used and the evidence to date. So with that, I'm going to end my presentation, and we'll have a Q&A where hopefully we'll discuss a bit further even these challenges and opportunities raised here. Thank you.
Great, thank you so much to our presenters. And I do note some questions have come up in the chat. What we're going to do for about the next 10 or 15 minutes is to spend a little bit of time and request our panelists to join us on video if they're able, so we can have a little deeper discussion on their work and their reflections on what segmentation approaches can bring to SBC programming and evidence generation. And so Jessica, your slide really started us off. That last slide on challenges and opportunities, I think got us started onto a nice footing. So let me start with that question to the group. And really asking for you what is sort of new about segmentation and what got you to consider these approaches for SBC programming. Maybe Leanne, because I think this was something that was different that you guys had tried. Can I throw that to you first to reflect on sort of some of the challenges and opportunities and what got you to consider segmentation?
Sure. I've been working, with SBC programs for quite some time, and I have used demographic and health surveys to do more demographic segmentations. But I think that there's a lot of value in looking more at the psychographic type question to sort of get a more nuanced picture of the types of audiences that that you're targeting, particularly in our situation in Niger, where there's kind of a lot of homogeneity within the demographic characteristics. And so it was kind of a value add to be able to look more specifically at maybe some nuances that may be occurring, in terms of partner communication or social norms, or if people sort of believe that they can practice the behavior. So we incorporated those types of questions into our survey because we had the opportunity, and use that to be able to generate the different behavioral profiles.
Thank you. Hannah, did you want to?
Sure. Yeah. So, your question was around why did we turn to this approach? So Surgo has used segmentation on a number of our programs, from maternal health, family planning to TB. And the reason why we turned to this was, in conversations with our partners, with the government, they were saying, well, what we've been doing hasn't been working. There was an uptake plateau, and the interventions, whether it was training community healthcare workers or doing other community mobilization or mass media or whatever it was, just simply wasn't working anymore. And there was a recognition that we needed to take a different, more precise approach. And so Surgo as an organization, data is very much in our DNA. And so we started looking into data. And what we found really quickly is that there's a lot of heterogeneity in terms of what people were doing it and why they were doing it. And so segmentation gave us a tool to, instead of rolling out 1,000 interventions, let's partner, say, what are the 5 things that we can do that really help to target individuals based on what's driving their behavior or what their particular barriers, beliefs, context, etc., in a way that was implementable, and it gave us a much more precise roadmap.
Thanks, Hannah. I think your point around heterogeneity really resonates with me. That has been the kind of reasoning that I have, and colleagues and I have used segmentation in some of the HIV work that we do, and sort of understanding whom to reach and understanding different profiles of adolescent girls and young women or men who are at risk for HIV or in communities that are at risk for HIV. So that's very interesting. Jessica, did you want to add to the reflections offered by Leanne and Hannah?
No, I don't have a lot to add. Just, yeah, I think as was recognized, segmentation is something that is often used. It's been used, for example, in the context of reproductive health, when there's youth programming that's already segmenting by age. And I think the addition here is the recognition that not all youth are the same. For example, they might have different aspirations and different barriers that should be addressed. And so that's where this approach or these different approaches might get one step further, which could be particularly relevant for really targeted and efficient SBC programming and communications. Thank you.
Thanks, Jessica. And maybe I can throw it back to you to talk a little bit more about the challenges that you mentioned. What are some of the challenges that you're seeing? You mentioned you have been working on these approaches, and segmentation doesn't just mean the quantitative segmentation. There are indeed a variety of methodological approaches within segmentation. What are some of the challenges that you see now? Once you do the analysis, how does this help shift SBC programming and really evaluation work? What are the challenges we need to overcome?
Sure. So I think one of the challenges that I've seen over time is, from the quantitative perspective, sort of the publicly available data sets often don't include kind of a rich set of behavioral determinant data, attitudes and social norms and that sort of thing, and self-efficacy. So I guess one of the limitations is that in order to be able to generate these types of analyses, you have to conduct your own survey. I think one thing that we've been advocating for is that there be more consideration of sort of the development of modules that capture some of these behavioral determinants that can be incorporated into the sort of publicly available data sets like DHS and PMA. And that could really help to sort of move the field forward in terms of incorporating more psychographic determinants into audience profiles. So that's, I think, one of the challenges. But I think another challenge, as you mentioned, is that it's not just quantitative approaches. And so I think one thing that is also can be quite effective is making sure that you do both a qualitative and a quantitative approach. So using the qualitative to sort of generate the types of questions you may want to test quantitatively after. So really trying to get more into the nuances within a community that may not be captured through sort of the more targeted questions that you see from a quantitative survey.
I agree entirely of that mixed method approach. And Hannah, your video spoke about that a little bit. Could you add some more details on Surgo's sort of mixed methods approach? And really, if you can talk a little bit more about your work, the work that the video mentioned, especially with healthcare providers. So a lot of the segmentation work that I'm familiar with, and some that the little bit that I've done myself, is
really with populations whom programs are trying to reach, rather than and not necessarily healthcare providers or sort of more systems approach. So I would love your reflection both on the mixed method pieces as well as sort of the populations that you guys were looking at.
Yeah, I want to echo Leanne in that I think mixed methods are absolutely important, and that's central to our approach. Really understanding the perspective of whether it's the community healthcare worker, a nurse, midwife, a woman, a family, spending time really first understanding kind of what's the universe of potential drivers, what is the local context, what are the dynamics that could influence behavior that simply it's hard to tease out in the qual, and then, or sorry, in a quant, and then doing a quant survey. In each instance, we almost always use mixed methods, but we may use different types of approaches based on the question that we're trying to answer. So for example, in the video, I talked about using journey maps. And for us, that was really important because a lot of existing surveys and research had asked community healthcare workers, well, tell us why you're doing something or not doing something. But that actually wasn't really getting into her experiences on a day-to-day basis. How was she interacting with the community? What was it like? And so we actually did several different qualitative methods to really tease out some of those things that may be harder to get by just kind of a direct questioning or a focus group approach. We also did decision games. So there, a lot of times people, at least in our experience, are hesitant. There may be certain norms, or in our case, when you're working with community healthcare workers who are government employees, there may be reluctance to share certain things. And so we actually use decision games as a way to try to uncover some of those. Instead of asking, what would you do? It was asking, what would this hypothetical person do? And why would they do that? So I think really spending some time thinking about what is the important question we want to ask, and then what's the right method to be able to do that, and really innovating in a way that we're not just kind of repeating, okay, I'm going to go do qualitative, I'm going to do focus groups, but really making sure that we're matching the right method to what we're trying to uncover. Your second question was around using community healthcare workers. I think this is, for us, is something that we hadn't seen done before, but through conversations with our partners, they had done a lot to improve community healthcare worker performance. They had rolled out new systems for payment monitoring. They had introduced a supervisory class cadre. They had done a lot of training, and they were saying, this is working, but only to a point. And so we said, okay, I think it's time to get more precise. And when you look at the numbers, there's actually 1 million community healthcare workers in India. In the state of Uttar Pradesh, I think it was 200,000 or 300,000. The number is huge. And so we went and said, a one-size-fits-all approach is probably not going to work to get you from this level to this level. And so that's where segmentation came in, where it was provided that roadmap for really understanding this large population. How are people different, and how can we be more precise with, frankly, really limited resources, that getting them to the people that need them the most, and getting the intervention to the person who needs that particular type.
Thank you, Hannah. That is fantastic. I love that. The possibility here is that we can use these more innovative analyses to do something in our very resource constrained environments. And I think that's really excellent. Jessica, any reflections on the points raised by Leanne and Hannah regarding both the mixed methods approach as well as how these can be applied in the segmentation approaches can be applied in public health, given your vast experience in doing this work in this field?
Yeah, I think the point around mixed methods and available data, I mentioned that there has been segmentation done based on DHS data. There was a really interesting one done looking at longitudinal data within DHS within the context of reproductive health. And that's referenced, and there's some links that will be going out that for people to find that. So really there's a lot of interesting things that can be done with not a lot of resources. I think oftentimes segmentation can be intimidating when you first start looking at it. In terms of use cases, it's interesting for the segmentations that are based on attitudes, beliefs, behaviors, things that you can't see with your eye, where you do need that profiling tool to find the person. We found that a really good use case is when there's a one-on-one interaction. For example, in Niger, we used a segmentation that we had conducted, a nationally representative survey, women 15 to 49, and created family planning counseling tool for providers, which was basically one page where the provider could sit down and ask a series of questions. So somewhat similar to the tool Hannah had shown in her video. The client answers the questions and the provider then knows which segment is sitting in front of her. And then there's a page per segment where the provider's been trained. And what was interesting is really the content is certainly different. The starting point of the conversation can often be quite different. If you're talking to a segment that really, has already used family planning methods, really trusts the provider. There's a lot of information we had around feelings and beliefs. And so you might be able to start the conversation a little further along, whereas for a certain segment or one segment in particular, it was really around building trust first and foremost, and making sure they knew that they had a safe and secure and reliable source of information if they needed to come back to that provider. So that example in Niger has been really successful and has been scaled up. We're currently in the process of simplifying it even further, making it easier to use. But the Ministry of Health really appreciated it as well, because it's not really expensive to do and to replicate. And the providers really enjoyed it. It seemed like it might take longer to conduct that sort of counseling in the beginning, but once the providers got used to using the tool, it was really a way for them to better understand their clients and to have a really much richer discussion. We've had
oh, no, please. I wanted to build off your example, but finish.
Oh, I'll mention one more example quickly. We've tried to use also in community-based programming. So under the Transform Far USA funded project, we used a screener and basically set up focus group discussions or community discussions amongst men in the community based on their segment. And that example worked really well in terms of having a focused discussion, and the discussions were different across the different groups. The only thing that was a little bit strange was that the participants weren't quite sure why they were being directed, based on the answers to these 5 questions, why they needed to go into the room on the left versus the room on the right. So for community-based, there was a little bit of that strangeness, but nevertheless, the intervention worked really well. So those are 2 examples, and I'll pass back to Hannah.
Well, you were talking about a tool for providers, and I just wanted to weigh in that I actually think there's a huge untapped opportunity with COVID-19 vaccines and tools for providers. I know one of the questions that people are asking is where else can we use this? And I see rolling out the COVID-19 vaccine as the single biggest opportunity right now facing us. Only half the global population is vaccinated, and in many countries, supply is finally catching up, but there's weak demand. And we know that we can't take a one-size-fits-all approach. And so segmentation provides us with a roadmap for more precise interventions. We've actually done this in the US. So we conducted the largest ever survey on vaccine hesitancy in the US. And what came out of that was 5 distinct personas of individuals in terms of their hesitancy or lack of hesitancy to get the vaccine. And we were able to take this research and turn it into a number of really practical on the ground programming, as well as using it to influence policy. So with this persona research campaign, there was a campaign all around Boston where people were going and knocking on doors, and it provided these community volunteers with the script of what to say based on individuals' particular barriers or beliefs, how to pitch it, what specifically to talk about. And there you can ask a few simple questions, understand what per segment or persona a person falls into, and then give a really tailored message. We're also doing this with health clinics that are running vaccination campaigns and that have been really, really successful, as well as for more broad kind of, I would say like US-wide, behavior change messaging. But I really see this approach of equipping providers with personalized information to help them have the right conversations as a really big opportunity and a use case for segmentation, and then with COVID-19 vaccines being one of the biggest challenges we're facing right now.
Thank you both for those reflections. Just going back to some of the things that Jessica, that you all have mentioned, I think it's that, then translating the kind of findings, the unique profiles, the segments from the segmentation approaches to programming, that, that is often, I find, the hardest step. So the kind of the typing tool or the simple questionnaire that Hannah and Jessica, you both mentioned, I think is a really key step. I feel that is often where some of the analysis falters or it stops too early. And then I also wonder if you can, I wonder if we are ready to shift programming to align with what we find in the segments. And if you see that kind of mismatch, because we're thinking about programs in a sort of a predetermined way. And if the segmentation tells us something different, how do we shift our programming approaches? So I don't know if that was a question or a comment, but for me personally, I find that there's often a gap there.
I think one important thing is that the segmentation shouldn't be done in a silo by a group of data scientists somewhere, far away from the actual program. When you're doing a segmentation, the end goal should always be, and how we operate is a particular implementation. I want to solve this problem, and with an understanding of what are my channels for intervention, how can I reach people, what is the universe of the things that we can do, so that when you develop your segmentation, it's actually implementable. When we've done our segmentations, we've actually taken a really iterative approach, bringing together our data scientists and then our people on the ground. So our government partners, our program partners, our program managers, and having it be actually a really collaborative exercise where it's not, oh, here's a segmentation, now you go and implement. But this, okay, what are really the questions we want to ask? How can we really interrogate the data together? What does this mean? And do it in an iterative way. So the end result is something that's really meaningful and implementable that can be turned into interventions.
Yeah, and I think that is a perfect segue for us to go to our chat. We have a number of questions in the chat. So, and our team has been collating and grouping them. So maybe I will just start with some of the first ones that have come up. Some are for everybody, some are for particular presenters. So Leanne, I think, well, actually this is one for the group. It says, while Leanne used latent class analysis, Surgo chose to identify segments through AI. So can the presenters reflect on those two approaches to analysis and why and when one might be used versus another?
Sure. I mean, for the latent class analysis, we used, we had the data accessible through the household survey, which was already part of an evaluation that was planned to assess differences in behavioral outcomes. So it was an opportunity to leverage that information that was already there in a unique way to be able to develop these audience profiles. So it was kind of more about leveraging information that was accessible.
And Hannah, did you?
Yeah, we actually use different types of algorithms to do our segmentation. And if I had my data science team, they could explain this way better than I can. But a lot of times we use unsupervised clustering algorithms, which is an AI-backed method that where we're trying to bring together a large number of variables. And what this algorithm does, it essentially tells you how are people the most similar in this group and this group and this group. But we've actually published a manuscript on this. I can put the link in the chat on different types of analysis techniques that you can use for segmentation, because I think a lot actually really depends on what the outcome you're trying to reach. We've also done segmentation where we looked at both psychobehavioral factors, but also included risk factors into that. So we did that specifically with TB care seeking. So we developed segments of the population based on, their likelihood of seeking care, why, demographics, but also their risk of contracting TB. And that was something that was really actionable for us, because not just having the segments, but then also having their risk help the government to prioritize, okay, we really need to reach this particular segment, which in this case was 60% of the risk of contracting TB. And I can put that journal in the chat as well. I'll put those two things and I'll send them to you
Thanks, Hannah.
afterward.
And we can also compile any resources and links and share out with the webinar when we send that out to the participants. One question that has come in, and I love this question because I think this is something I have been grappling with as a researcher, is are there methods to measure whether and how often people move between segments over time? So a lot of the segmentation work we've talked about today on this webinar has been using cross-sectional or one-time point data. So I'd love it if all three of you could reflect on this a little bit, is how do we look at sort of movement of people over time within segments, or how do segments change over time? I think this is a really key piece, especially for any kind of research or evaluation work related to social and behavior change programming.
Yes, Jessica, just some initial thoughts. It's definitely a question that's come up before. I think we're working with Catholic Relief Services in Niger and wanting to integrate essentially the profiling tool into their baseline and endline survey so that they could see if there was changes over that year. And you can imagine that by segment, there might be changes if you had some programming really focused on addressing barriers or challenges for a particular segment. Maybe some of the behaviors of that particular segment would have changed. And you could imagine that some people would change from segment to segment. I think one thing that we discussed in that context is how fixed is a segmentation? I think in the world of high tech, they probably have to do segmentations every month or so in terms of people's tech habits and things that are just really rapidly changing. If we're talking about a segmentation based on a health behavior that has really a lot of entrenched social norms and yeah, frankly, a bit more slower moving in terms of changing behaviors and beliefs around it, segmentations will probably hold for a bit longer. And therefore, you might imagine that segmentation might hold and you'd see some differences within the individual segments. I'll stop there and see what my...
That's really helpful reflections, Jessica. Yeah, Hannah or Leanne, anything to add?
So I think that I actually agree with everything that Jessica said. I think that the amount of movement between segments really does vary by what the type of behavior it is. So right now we're actually tracking movement across segments when it comes to COVID-19 vaccination, but that's a 1, 2, or hopefully not more than 3, but who knows, time behavior, where we're seeing groups from, say, segments who were maybe a little bit hesitant earlier move into the vaccinated group. And some of the segments aren't doing that. And so how we're measuring that is we're using really rapid data collection, where similar to the typing tool that we showed in the video, we actually have the same type of typing tool for COVID-19 vaccines, where you can ask 5 questions, quickly understand which segment someone's belongs to, and then track the movement across segments. So we've been doing that over the past, I think, 8 or 9 months, and we did see a number of people move from certain segments into a vaccinated, but then some people actually didn't move, and that really depends on kind of the level of entrenched.
And Hannah, that kind of tracking of, if I can follow up, that tracking of movement required additional data collection or repeat data collection. So Jessica mentioned that they've sort of, in her example, for example, with CRS, they're working to integrate some of these questions into like baseline and inline surveys. Is your sort of looking at that tracking movement repeat data collection as well?
Yeah, it is. It's a repeat data collection on the Facebook platform, where we were actually able to partner with another organization who does this type of data collection on COVID, and then we added our segment typing tool. There are ways you can do this where it's if tracking segments is over a short amount of time is something important to you, then there's ways you can do this rapidly. I think to Jessica's point, how important is it to get an understanding of how these are moving, you know, at what's the right time horizon? If it's a harder to move behavior, a baseline and inline would make a lot of sense. If it's something that like COVID vaccines, where you're trying to make changes to your campaigns on a monthly basis, then that's something where you're going to want to do more regular tracking of segments.
I was just going to add to Sanyukta that I think this kind of speaks a bit to the methodology in terms of when you use surveys and when you, look at other methodologies. I'm not as familiar with AI, but we've used social listening to be able to track over time in social media, and you get sort of rapid information from social media in terms of, the sort of conversations and posts related to particular behaviors that you can sort of leverage for that type of information as well.
That's helpful, Leanne, and I think we can put the social media listening chat as a list of resources too, if folks are interested. There's a couple of questions that have come in that I think are really relevant for this audience, and if the panelists could reflect on this. Folks are asking if you can shed more light on how segmentation has improved efficacy of the behavior change messages. So any concrete examples? Maybe Jessica, I can throw that to you first, given some of the programs you had mentioned.
Sure. Well, I think the example of the family planning counseling cards that were developed, I think one of the reasons it didn't take longer to use the segmentation tool is because instead of having to talk about every topic with every client, the provider was then directed a bit towards, okay, what are the 3 things that I really should get across in this conversation? And so that helped the provider in that case be more efficient. We've also did some testing in terms of doing iterative A/B testing of messages, which we tried to do using a IVR platform, interactive voice response, where we could segment the women calling in, and they would listen to a set of messages, and then we would get some responses and then quickly iterate on the messaging itself. So it allows for opportunities to have some really targeted messages based on segments and adjust those. Let me see if my colleagues have some other examples as well.
I think, can I add one more question to that? And I think it's sort of related to some of the questions that are coming up, which is around the efficacy, but also and better understanding how these approaches are different from the analytical approaches that are currently used in social and behavior change programming. So one example is, for example, the doer non-doer analysis, which is commonly used, very effectively used in SBC programming. So are there any reflections from the team on the usefulness of segmentation versus doer non-doer analyses and how that relates to some SBC programming? And I think that may be our last question. Sorry, just realized the time. Jessica or Leanne or Hannah, any reflections on that last question?
I'm not familiar with the doer non-doer research, but the comment I was going to try to put in the chat earlier on this was And I think it's important to note at the outset of a segmentation effort, obviously very important to define the audience that you want to reach out to. But then the second is what is the outcome of interest? What is the behavior? Is it doer, non-doer? Is it someone who's doing a certain action versus those who are not? And oftentimes those are the outcome variables, if it's quantitative, but also qualitative, that everything else is sort of judged against to see if there's some correlation or some patterns in behavior against. That being said, since I don't know what doer, non-doer segmentation is, I'll be quiet and let others speak up.
I think I'm with Jessica. I haven't used that particular approach in our programs, but I think that what segmentation does is it tells you about the heterogeneity, right? In the reasons why people may do or not do a certain behavior, and that it's not necessarily all the same for everyone. Some people may face structural barriers. It's just too far to get to a clinic to go get family planning, contraception, or counseling. Others may face perceptual barriers. I don't want to put anything in my body. And segmentation provides you a way of really quantifying how these are different for different groups so that we better know how to intervene. I would say, though, that segmentation is not like a silver bullet, right? There are so many different approaches and methodologies in social and behavior change that it's really important for someone to think about what is the problem we need to solve? What is the context in which this exists? What are the local realities? What are the social norms, the structures in a community? And not just say, oh, we need segmentation here, but really, what is the problem that we're trying to solve for, and agree on that with partners. And then segmentation is one tool of many different approaches that can be used in social and behavior change programming.
So Hannah, I think that was like the perfect last comment to close out this webinar. Thank you to everyone who's joined this conversation. I hope it's been a helpful and an engaging hour. We are going to thank you to the presenters who've joined us, some from different time zones, and to the many participants on the webinar. We will be sharing out the webinar recordings as well as the resources that have been popped in during the chat during the webinar, as well as additional ones that mentioned by the presenters in a few days. And thank you again for joining, and have a great day.